Long journeys. The journeys are even longer if you get confused between Mount Vernon and Mount Florida. I think you've been spoken at a bit too much. I'd like to do something if people are brave. Could everyone shut their eyes? Everybody shut their eyes for a second. And just put your hand up if you're comfortable. You don't have to. If you've had a mental health issue in the last 5 years. Okay. Just wanted to acknowledge that. Okay, hands down. Now, I want you to bring to mind, because you've been spoken at far too much. I want you to bring to mind, to sit quiet and bring to mind in the last week, month, an experience you've had where you've been nurtured or helped or supported by another person, just a nice rich one. Yeah, you got that? Can you bring it to mind? Has anyone not got one of those in mind? It's a universal experience. Almost. Could people, if they just turn to the person next to them, don't tell them the whole story, just tell them enough of a label to say what it was. Just turn to the person next to you and say, what was that nurturing experience? Go. Okay, hello. Okay, everybody, time up. Now, isn't it good to bring things like that to mind? Isn't it enriching? Mine, I was thinking, I've had the privilege of being part of a lifestyle management group at the Thistle Foundation in Craigmillar. And the experience of seeing people from week 1 to week 4 has been extraordinary. And I'm thinking of one particular guy who almost didn't manage to stay for the first session and has now started to feel his life come back together. And it's just fantastic. And that's, for me, just being part of that mutual enriching experience has been spot on. Right. My name is Tim. Who gets the reference? My name is Tim. And Tim Warren, I was until this summer the policy lead for self-management and health literacy in Scottish Government, along with a colleague who's the clinical lead, Graham Kramer. I'm saying his name just now because I'm quite likely to mention him again. And since the summer, since August, I've been seconded to the Alliance to support the spread and adoption of the House of Care. Now, could you put your hands up if you don't know about the House of Care? Great. I had the strange experience yesterday of doing a WebEx, a webinar, where you talk at a computer screen to a bunch of people you can't see and you can't hear. It's a strange one, all about this. Okay, Scotland's House of Care. I've got the control. Graham likes to use this slide. He says that being diagnosed with a long-term condition is a bit like being dumped here. So if you could mentally put yourself here, having lived in a nice cold climate, imagine yourself there. From here on in, this is your life, you're going to live there. How does it feel? Where are you going to get your food? Shelter? Are the natives friendly? How are you going to protect yourself from the consequences of jungle living? Yeah, it's quite thought. And this is a slide that's been used in lots of settings, and it was produced by at a World Cafe event where people were sitting around tables like this, and then they wrote on the tablecloths. I don't think we've got permission to write.
Post-it notes.
Well, post-it notes, perfect. I don't know how people can see, but you've got the green wavy line of the person living their life with a long-term condition. And I'm very struck by a phrase that Stuart Mercer, who's a professor at Glasgow and a GP, says that you have to think, what impact does this condition, this mental health problem, these conditions have on a person's life? And what effects does, or what impacts does this person's life have on their condition? It's absolutely whole person. It's not just about the biomedical. But then, clattering into it, we get these red lines. So if you have diabetes, you have these regular appointments, these episodic consultations, which may be useful or useless. They may not help a person live well, or they may help a person live well. They may help the person in living on that green line. But it is the green line that's important. Now, nationally, we have a few problems. We've got the issues of the aging population, more and more people having multiple conditions. It's more common to have more than one condition. What's the most common comorbidity for a heart attack? Depression. How can we best help people to be in the driving seat of their care and to live with any conditions they have? That's critical. And it's a complex world. Now, after all the presentations this morning and the diagrams, how many people can remember what was said? It's hard. It's hard. Is it confusing? And all these different government policies and strands, it's murder. It's a complex world. And Shona asked me to reference wicked problems, and there are lots of wicked problems. So, some of those many things you need to know about. You've got all this, you're going to learn this, I'm going to question you afterwards, yes? Yeah. We've got, these are the different elements from the person-centred bit of the quality strategy. So, who doesn't know about the quality strategy? Scottish Government? 3 parts of it. Person-centred, safe, effective. This is just the sub-elements of person-centred. Got all that? Okay. And then, you could have an and I'm sure that people will say, why isn't a thing up there? So we've got the mental health strategy for Scotland, people-powered health and wellbeing, personal outcomes, talking points, co-creating health, new models of primary care, NUCA, links worker programme, integration of health and social care, self-directed support, connecting people to local opportunities, social prescribing, improvement in evidence, compassion. Feeling tired, anybody? In thinking about this, coming into my job in Scottish Government a few years ago, I just thought a Fats Domino record summed up poor me. How the hell are you supposed to keep abreast of all this and make sense of it and have a sense of purpose and vision and not always be ambushed by new things coming down the corner that you don't know about? So I've had, there were very useful touchstones for me, and I think I've shortened these, but one was this King's Fund report from, 3 years ago on self-management, that said you can think of it as a bunch of techniques that Frank in a former life might have done to his patients to get them to do what he wanted them to do. Before he saw it as a fundamental transformation of the patient-caregiver relationship into a collaborative partnership, where people come in and say, I don't want drugs. Where people, yeah. And then sitting down with Shona yesterday talking about this presentation. So this is just like shifting the balance of care to community-based co-production, like what Shona said. There you go. And then could somebody save me? I think they called it this to embarrass this Sassenach, who always struggles to say, go on yourself. Could someone say it for me? Thank you. And obviously, self-management strategy for Scotland, written by the third sector and adopted by government. I haven't heard of that happening in any other domain. And the key, it's got 5 principles, but the one that I touched on is I'm the leading partner in the management of my own health. Or in the driving seat of my care is the little phrase that I noticed Sarah using, that's helpful. But then there's the house of care. For me, this is a touchstone, a helpful way of organising all the different activities that we are rightly talking about today. And just to say the basics, it says there are 4 critical elements and a bit in the middle. And it says if you haven't got all 4, the bit in the middle will not stay warm and safe and dry. And now I'm going to say, what are those 4 elements? The one in the middle I should start with. Now, we in order to have a label, a short label, we have person-centred care and support planning. But actually, it includes the mental, physical and social well-being, shared decision-making. It's informed absolutely by personal outcomes. A nice example of that is the talking points work and co-creating health. And I'm sure from just what we've heard today, there are other things we could add in there. But yeah, we tend to call it care and support planning conversation, which is at the centre of the house. And this afternoon I'm doing a workshop which will be about care and support planning. Really, in this presentation to everyone here, having spoken with Shona, this is just about the usefulness of the house as a very memorable way of remembering the things that need to be there to support people, to enable them to be in the driving seat of their care. To say the same thing again, those red lines on the wavy green line, what those red lines need to have to make it work any longer. I'm going to steal someone's water. The two side pillars, you've got engaged, informed, empowered individuals and carers, and the health and social care team committed to partnership working. And there are little phrases that are used about there are 2 experts in the room. There's an expertise that people with the lived experience of having a long-term condition bring into that isn't the doctors, it's their knowledge and wisdom and experience. But then you also, for them to be engaged and empowered, they need things like information. They need information in a format that helps and supports them. Then you have the health and care team. It's very easy for it to be me, doctor, you, Jane, sit there, I will prescribe exactly the drugs you need, not really listening. Graham Kramer said he met a student nurse, master's level, from Taiwan, who was told if any of their nurses or doctors were caught talking to a patient, they would be disciplined. We're better than some places. So these are the sorts of things that are necessary to support the engaged, informed, empowered individuals and carers. And so having the results in advance, knowing your test results in advance, and having space and time to make sense and to bring something to the consultation, that's very important. Structured education, which is designed by peers, by not just other people. And then a recognition of assets, that someone comes in with assets. You never know, you might discover that the person coming in is a poet. And then emotional and psychological support. I realise do I need to, can people still hear me? Okay. Then on the right-hand side, consultation skills and attitudes, that they need to be different from possibly the traditional ones which do ask many more open questions and say, what matters to you? What's important to you? What matters to you? Which may not be the biomedical. It may be like the chap that I met in the group at the Thistle, being able to play with his granddaughter, and being able to get back up off the floor. More than medicine, I think that was, Frank didn't use that phrase, but it's not just the tablets, it's more than medicine that people need. And we've got these 4 tiles across the bottom where you have to map your assets, you have to have a mechanism for making them available and visible and findable, which is ALISS. Then you need support for joining people with their local assets. Some people, signposting isn't enough, referral isn't enough, and nodding again to Mark at the back of the room and the Links Worker project, you may need someone to chum the person along the road to the project. And then the individual information, the needs gathered, need to be aggregated to inform joint strategic commissioning. There's a scary word, particularly in this new joint bodies world. And then you've got the organisational processes. As Frank alluded, he has had the opportunity to have some longer appointment times, and that's only manageable if you do something about the contracts. That's one example. Another would be the IT system being able to send stuff out in advance. So, and it's that, all of those together that lead to improved outcomes for people. That's people being in the driving seat of their care. So that's the whole house. And some comments that people have made. It helps me make sense of a really complex world. It plays nicely with the other children in the playground, meaning that using the house doesn't mean that you have to abandon other models. It just says, it expresses some of the bits, and you can say how the house works. And it was this conversation I had with Shona that she said, absolutely, that's why we need to make reference to it. You could be talking about the Links Worker program or many others that fit nicely with it. Someone else said, there's nothing new here. It's true, there's nothing new here. But what there is a nice articulation of the different elements that need to be in place to make it work. And it has given me, said someone even yesterday, an overview of how the system should and could work. And so what's the House of Care useful for? Hey, a bunch of things. So, lastly, Isabel Hodkinson, who was a lead GP in Tower Hamlets, where the House of Care was used, said that the centre of the house is a fragile flower. It's a conversation. And sometimes people find the model so exciting they put something else there, like a plan or outcomes. It's a conversation between two experts in a room. And now I have to quickly go off and come back on and say, I'm now Jane Ann Corey. Jane has had a very sick 5-year-old, and so sympathy to Jane. It's been going on for several days, and it's horrible stuff, and I think she'll be fine, but she's in misery at the moment. So she said, Tim, would I come and do the presentation? I said, of course. I was passionately involved with ALISS from not quite the get-go. I saw Christine here. Christine was here from the get-go, but I wasn't. ALISS stands for a local information system for Scotland. And I printed off Jane's notes, which were great. It began in, a little bit about the origins of ALISS. It began in 2009 with a small exercise in ethnographic research. I like that word. One man filmed his journey of seeking support in his community to help him live well with arthritis and depression. His experience in film was used in a next stage with an adult literacy group. Then there was an adult learners health literacy group. Health literacy, you notice this is about health literacy. 12 adults spent a week seeking support in their community. They missed the resources they knew were there and found it hard to articulate what it was they were looking for. Familiar stuff. Then in 2010, there were co-design workshops. I think the co-design, if we're talking about services for people, just this nice thing that needs to be designed with people, implemented with people, and improved with people. You can't, if you start to see people with the conditions, people done for or to, it's not, and not with, it's not for them. What keeps you well was the key question. We've already had a little bit of that. What keeps you well? And it's the connection, those discussions that you had, those nurturing experiences and expanded and multiplied. So, what keeps you well? Local resources. Barriers to accessing the resources. You don't know where to look. It's hard to say what you need. How many people have been to the GP in the last year? How many of you picked up a leaflet from the wall? And I'm guessing that there were a lot of leaflets available. Yeah? Information in lots of directories there's lots of duplication, stuff's out of date, and there's lots of information that's not published at all. So what do people need and want? One view, one way of finding and looking at their assets, and help to manage those information assets. And then that led on to the Links project, which was where government gave a little bit of money to 10 GP practices, 6 in Glasgow and 4 in Fife. Christine again led on this work brilliantly. And it was to enable those primary care practices to find out what assets there were in their community, just to give them a little bit of breathing space to do that. And one of the findings, the key findings they had, was a lack of awareness within the practices about those local sources of support. So this is where, with Jane's permission, I went to some of my slides that I used to talk about ALISS, which is a straightforward analogy, which is Reuters, that many health boards, like the Times, or organisations, say Alzheimer's Scotland, Telegraph, or perhaps something that's very local, Craig Miller, create databases of assets in their communities. And they frequently overlap with each other, and they duplicate each other. And there's quite a lot of work goes into keeping them up to date, and it's hard graft. And often you only need to find something's not up to date a couple of times, and you say, the whole thing's useless, and people weep over them. What ALISS is like Reuters to the newspapers. If the Times discovers a story, it publishes it, and it republishes it to Reuters, which is then feeds back down into the Telegraph and the Guardian. ALISS is not the Times, so there are still many excellent directories, and the point about ALISS is that by plugging into ALISS, they get their sources widened and broadened, and they get more people using it. This bit here says hyperlocal and locally relevant assets. A tiny story about Graham, my colleague. He was in his surgery, and he asked a question, which he's begun to ask quite often as a way of populating ALISS. He said to a woman who was there, what helps you keep well? And she'd had a stroke, and she had started a stroke club that met in a cafe on a Wednesday in Montrose. So Graham duly Googled Montrose and stroke, and came up with Montrose, Colorado. Didn't know there was a Montrose in Colorado, did you? And with Chest, Heart and Stroke Scotland. Both correct, and neither hyperlocal. So he, as a reporter for ALISS, put a reference into ALISS, reported the story, wrote it up as it were, and then Googled it, and it was the #1 hit after the paid-for sites. So that's the genius. This is something that wasn't possible for our forebears, and it is now. Yeah. ALISS is not about the mad, the bad, and the dangerous. It's about the quality-assured stuff. And it is about capturing the things that people find help them to stay well. So the swimming club, or the group of people that meet at the swimming pool on a Monday afternoon that's not official, as well as the official things, the lists of local services. And it does allow people to be fussy, so that if a GP is fussy and says, I'm only prepared to take resources which have been endorsed by my fellow GPs, he can, she can, either. They just say, I want my feed to only be about these practices, and that's all that appears on their site. So it allows, that's how it addresses the issues of quality assurance. And these are back to Jane's slides, which is lots of sources into the ALISS engine, and then it's republished in lots of different ways. And so here are some of the ways it is republished in GP systems, libraries, Living It Up, Police Scotland, Community Pharmacy, prisons are using it. SFRS, which I don't know what it stands for, TSI website, Third Sector Interface website, Housing Association, any website. And it could be a local group, an NHS service and an event, and they can all be put in there, and the sources of that information are on the right. This is Living It Up's use of ALISS, so they're making use of it. Perth and Kinross, Well Connected. This is another organisation that's made use of it. Glasgow City, Glasgow CHP South Sector, again, using ALISS. And Then Jane helpfully had a nice picture of the house. Yes, so these are some of the things that are going on, and contacts. And thank you. Okay.